Thank you all. Good afternoon, and I'll again try to stick to my time point here. So, as I said, thank you, Dr. Singh, for inviting and the task force for me to address this body. I'm Dr. Buvanendran. I'm here from Rush University Medical Center from Chicago on behalf of the 52,000 members of the American Society of Anesthesiologists as the chair of the ASA Pain Committee. On a clinical basis, I do both acute and chronic pain. However, today I'm only going to be talking about acute pain, as Peter and Andrew have already touched heavily on the chronic pain side. ASA supports policies and best practices that minimize opioid use and helps prevent misuse, abuse, and addiction. Anesthesiologists are the leading physician group in the operating room, which extends into the post-operative period. ASA would like to propose that the perioperative surgical home be considered as an advanced alternative payment model system. Anesthesiologists play an integral role in the post-operative opioid of pain management, and especially opioids being discharged home on. It is critical to realize that the severity of the surgical post-operative pain is varied. It can be as simple as a foot bunion surgery or as a big surgery such as thoracotomy, and having blanket statements encompassing the number of pills prescribed for any surgical procedure would not be reasonable. However, having the perioperative physician be part of this process and determining the appropriate quantity of opioid discharge and appropriately figuring out a multimodal discharge pattern for these patients and the number of opioids prescribed at discharge home will certainly decrease the number of opioids that our patients take home, and which will prevent the secondary users and tertiary users of the opioids that are left in the cabinets of our patients, and therefore decrease the opioid misuse and abuse. Many patients' opioids first exposure is to opioids as a surgical experience, and for some, this can lead to opioid abuse and misuse. Studies find that the prescription of an opioid at discharge is an independent risk factor for chronic opioid use 1 year later. Physician anesthesiologists play a critical role in the delivery of care, for it makes them integral to reduce the opioid utilization during the perioperative period, during the postoperative period, and in fact, using opioid-sparing techniques with regional techniques and multimodal analgesia to decrease the opioid utilization even at discharge. Physician anesthesiologists are integrated and participate extensively in implementing best practices and promote minimized opioid use in the perioperative period. ASA believes the task force can leverage these efforts and build upon the work that is already being done. The Society encourages HSS to support innovative programs that encourage opioid-sparing techniques in the hospital and surgical setting. This might be carried out through nationwide demonstration programs that utilize expertise of physician anesthesiologists and surgeons and other healthcare providers. In preparing for surgery, physician anesthesiologists can use alternatives to opioids relieving techniques and protocols, such as the regional techniques demonstrated over here with the utilization of ultrasound, where local anesthetics can be applied to the nerves to decrease pain. Furthermore, multimodal techniques utilizing various pharmacological non-opioid drugs can be administered in a comprehensive fashion from the preoperative period to the intraoperative period, into the postoperative period, and at discharge home, and all decreasing the utilization of opioids and opioid exposure to our patients who are having surgery in this country. So as partnering programs, ASA is in fact partnering with the American Association of Orthopedic Surgeons, the AOS, to develop task force that's already been underway to develop guidelines on what should be the appropriate quantity of opioids or multimodal regimes that should be prescribed for patients having orthopedic surgery and going home after discharge programs. It is not just prescribing the quantity of opioids, but trying to figure out what is the appropriate quantity with the multimodal regime that these patients should be going home after an orthopedic surgical procedure. This initial partnership of ASA and ASAOS will lead the pathway to future collaborations with other major medical societies and hopefully come up with the guidelines that can provide for the acute perioperative period. The American Society of Anesthesiologists has partnered with Hospital Innovation Improvement Networks to join a unique program, a pilot program, where anesthesiologists from the ASA gave series of webinars and interventions for 32 hospitals across the country over the last 6 months. This was a pilot program that we intervened on specifically three large surgical procedures. Our preliminary data has demonstrated, after intervening for 6 months in providing education and developing a multidisciplinary approach, that we could significantly reduce the high dose of opioid prescribers of greater than 90 morphine milliequivalents significantly in the post-operative surgical period. Furthermore, we were also able to decrease opioid utilization in these three surgical categories across the board while these patients were in the hospital. So opioid sparing techniques used to treat acute and chronic pain is integral. And I believe large hospitals have already undertaken several of these programs. However, disseminating this information to smaller hospitals and across the country is very critical. And I believe this is where we could use the resources of HSS and the other health agencies to disseminate guidelines that have been developed. ASA also believes that there are opportunities for HSS to leverage the expertise of anesthesiologists to prevent the opioid misuse and abuse as well. Medical specialty societies should be considered eligible entities when the agency is allocating resources to combat the opioid epidemic. HSS would support innovative models that reduce opioid use, such as opioid-sparing protocols that have been developed by perioperative physicians, as mentioned before. ASA is pleased to see that several of the bills have been passed in the Congress, and instead of me listing several of them, ASA has been very integral and supportive of several of these House and Senate bills that have been recently passed. It is also important to realize, in my last 1 minute, I'm going to close off by saying acute pain can lead to chronic pain. It's important to realize that if we can figure out patients not to get exposed to these opioids in the perioperative period or the acute stage, we can essentially decrease this opioid utilization for these patients who develop chronic pain. And perioperative physicians have been doing research in trying to figure out this transition process from acute to chronic pain, and we can essentially be able to prevent some of these patients from getting from acute to chronic pain, and thereby eliminating the utilization of opioids for these chronic pain patients. Thank you very much for your attention.